Hi friends, I am Dr. Ashutosh Gupta and let us talk about double aortic arch, right? So in the fetus, there are two arches, right and the left. Both of them they persist and then they fuse together behind the trachea and the esophagus. So there's behind the windpipe and the food pipe, right? And what we've identified is this that some associations with 22q microdeletion, which we believe is the commonest microdeletion to happen. It is some associations they do exist, but the potential to have this 22q microdeletion is less as compared to the connotrunctal malformations like truncus arteriosus or a TOF, right? And since there is a vascular ring which is going behind the trachea and the esophagus, and therefore we can have some issues regarding an stridor. We can have some wheezing. We can have some feeding difficulties, right, after the baby is born, and therefore we might need to do a sort of a tracheal intubation, might need after the baby is born, right? So let us talk about this double aortic arch. Let us first see the images, that how does it look like, and therefore, and then we did the invasive testing to the baby, and then what remains to be the most likely postnatal outcome. To look closely, so this is a 3V TR, three vessel trachea view. So probably I am focusing onto the trachea which has come between the pulmonary trunk and the arch of aorta, right? When we are putting this low flow velocity, so what we can identify is this complete sort of an encircling of the vascular ring behind the trachea and the esophagus. Okay, so trachea can be looked around and adjusted in between this vascular ring, right? So this is a double aortic arch. So now what happens is this, that the aortic arches are both on the right and the left, and then they fuse together, and therefore it persists, and therefore it is called as a double aortic arch, right? Or eventuality is this, that we try to look around for the thymus, but then also this could be a marker for 22q microdeletion. This is a very big area in which we can have some variable degree of sort of an microdeletions. So the aortic arch, right and the left, they persist, they fuse together, they make a vascular ring behind the trachea and the esophagus, and this could be isolated or syndromic. Mostly, what we believe is this, that the potential to have a microdeletion of 22q is slightly less in double aortic arch as compared to the conotruncal malformation, which could be truncus arteriosus or a DORV, and they can be symptomatic, meaning thereby that since a vascular ring is going behind the trachea, we can have a tracheomalacia leading to some sort of an stridor or sort of an respiratory difficulties. We can have some feeding difficulties even, because then it presses upon to the esophagus, and therefore we can have, so some sort of a close observation is required. And eventuality is this, that in these isolated cases the prognosis is sort of an good. If required, we might sort of an that small sort of an arch could need the resection after the baby is born, and then the long term prognosis is really good. And this 22q microdeletion, this is one of the commonest sort of a microdeletion that can happen, and 1 to 2% of the fetuses and the babies they can have it. And so whenever we are identifying some abnormalities, like conotruncal malformation or DORV, or we are identifying this right or a double aortic arch, definitely an invasive testing is warranted. In fact, in which we can really look around for that complete area by doing the MLPA, FISH, or a QFPCR, or by doing a CMA. And there could be a nested sort of an proximal microdeletion which is of 1.5 MB, which might get missed by doing the NIPT. So the prerequisite between the routine NIPT and NIPT with microdeletion is variable, meaning thereby that the fetal fraction has to be greater than 4% in a routine NIPT. In a routine NIPT for common aneuploidies, vis-a-vis when we are doing for microdeletions, it has to be greater than 8%. First, and secondly, the microdeletion that is of area of interest whenever we are seeing this NIPT, the deletion has to be greater than 3 MB. Therefore, it can get picked up by the NIPT for microdeletions. So the nested microdeletions, which could be a proximal part of 1.5 MB, can very well be missed by this NIPT with microdeletions. We can have duplications even, which might not be. So this area eventuality can have some deletions also, but duplications also. So duplications would not be picked up by doing the NIPT. So whenever we are identifying some sort of a malformation, whatever it is there, so definitely in invasive testing is warranted. So if it turns out to be normal, which has happened in our case, so the prognosis is likely to be good. We can even try to look around for polyhydramnios if that vascular ring is pressing onto the esophagus, and therefore we can have this fair amount of an idea whether this would create some troubles to the baby. So we did all these things are being done at 20 weeks. We did the amnio. Within 2 weeks, the reports are there. We keep the baby under surveillance. Surveillance is only for polyhydramnios. So if we believe that the vascular ring is pressing on to the esophagus and therefore there would be difficulty in swallowing of the amniotic fluid to the fetus and therefore leading to polyhydramnios. So in these cases, if we identify the polyhydramnios, we can identify that the vascular ring which is going behind the trachea and esophagus could be tight, and therefore we might need a tertiary care delivery to the baby, right? Okay, this is what all probably I wish to tell you about double aortic arch. Thank you very much for your patience.